Hi friends, welcome back to my channel. My name is Olaoluwa Fajimi. Recently I started a three-part series explaining what each feedback statement of the SCA examiner's feedback means. This is rather important because many do not make sense of their SCA examiner's report and so are not able to tell for sure what they have done wrong or what they need to do differently whilst retaking the exam. Even those that haven't taken the exam are not exactly sure what the examiners are looking for. So this series is an attempt to clarify exactly what the examiners are looking for and what those who have taken it, who have had one or two of those statements chosen, what they need to do going forward in order to succeed in this exam. If you haven't seen my first two videos, please do so alongside this third one. In today's video, I'm going to be describing the feedback statement as made available by the RCGP on Domain 3. Domain 3 is the one that is called Relating to Others, RTO. This domain is what used to be called interpersonal skills. Now, you will agree with me that a lot of IMGs find interpersonal skills rather challenging. I did myself. It's challenging because it's one area that tests how incorporated into the society you are. It's one area that tests how you're able to use your social understanding of your patient in order to help your patient and as such pass the exam. Without making and wasting much of your time, I will go straight into each statement. Number one is the communication skills, including non-verbal skills. The responses to cues and active listening were insufficiently demonstrated. And what this means is that the doctor did not communicate well. The doctor did not pick up cues that the patient was choosing to release to them. It may mean that the doctor came out formulaic and it appears they've got a structure which they rigidly followed. If, for example, you repeat, "Oh, I'm sorry to hear that," all the time, it almost comes like this doctor has been coached and trained to do so. And so even when the situation doesn't exactly demand it, the doctor goes ahead to say the same thing. So should that be the case, the examiner will mark the doctor down and pick this option to justify marking them down. So what do we do to this? It involves active listening, so paying attention and responding appropriately, establishing that relationship with the patient such that it helps to clarify anything unsure and making short summaries such that important points that may have been missed are brought back to fore. What to do is to avoid being formulaic, to have a structure, yes, but also at the same time be flexible with your model. The second one is that the patient's agenda, health beliefs, and preferences were insufficiently explored. And many times this relates to the eyes. It relates to the context of the illness. How has this illness affected this patient, first and foremost? How has it affected them? For instance, a patient whose close relative has a lung cancer may have a straightforward cough that's an upper respiratory tract infection, but they may be legitimately worried that this might be lung cancer just because their relative who's got lung cancer had similar symptoms. So if the doctor doesn't explore that part of the illness, there is no way this understanding, this health belief of the patient will be brought out. And the way the college has suggested to do this is that in your consultation to always explore ideas, concerns, and expectation. And when these are not sufficiently explored, to then ask further questions on them. You can ask about a patient idea and they go, "Yeah, just so what happened doesn't happen again." you need to then dig deep. Oh, sorry about that, but what actually happened? Such that you can begin to understand exactly where the patient is coming from. The next one is that the circumstances, relevant cultural differences, and preferences were insufficiently responded to. And what this means that one did not make full use of the provided information, both the ones provided by the patient and the one provided in the task. That the doctor did not actually get into proper partnership, such that it almost seems like it's the doctor's agenda that got satisfied. For instance, if a patient has come with cough again, from your point of view, that cough may be nothing but a reflux kind of cough. But from the patient's point of view, they may be worried about a TB just because they've been to a TB belt and they've seen a lot of people with it. So it's important not just to respond to your own preferences, but also to bring the patient's preferences into it. And how to do this is to always explore what the patient's preferences would be. What would you rather we did in here? Such that when there are differences in your own preference and the patient's preference, what you then need to focus on will be to find a middle ground. Next one is that the explanation were inadequately shared or adopted for the patient's needs. One of the commonest things that happen in here is the use of jargon. This lesion is nothing important. The patient does not understand what you mean by lesion. And one of the things I always encourage my friends to do really is to list out all major conditions and look at how to explain them in simple English. It's something that comes like, oh, it's so easy, but it's actually so difficult. So if your explanations are unclear and the patient needed to clarify or the patient remain unsure, then this is the option the examiner is going to pick. And so what are the areas of suggestion as per the college is to explore more communication techniques and use materials that help to adapt simple, plain explanation that the common person on the streets will easily understand. The next one is that a judgmental approach was shown to the patient. A judgmental approach does not actually mean until we clearly are judgmental against them. Many times they are subtle. They can be expressed, they can be perceived, but they can be picked up as well. If, for instance, you see a 16-year-old who has got pregnant from unprotected intercourse, and the way you go about it, and you're only 16, and you did this, will mean that one is being judgmental to the patient. So when the examiners feel that judgment was conferred and that our role to look for solution was not actually done, rather our role to summarize the issue, to confirm what sort of person we think the patient is, comes more to the fore, then that will be the option the examiners are going to pick. So it's important to look at all protected characteristics and generate empathetic responses to each person such that we deal with everyone with respect and equally. And what the college has suggested is that, rightfully so, yes, we all carry on unconscious biases, and that we should recognize which consultations are likely to challenge and bring our unconscious biases to the fore. And so those are the ones we need to be more careful and to understand that people may be more vulnerable and more susceptible to health problems when they carry many of those protected characteristics. Number 6 is respect and or sensitivity shown to the patient was inadequate. And a common example of this is consent not being taken. Is we wanting to do an intimate examination, but we did not actually offer them a chaperone. So when the examiner gets this impression that were not respectful enough to the patient, then this option will be picked. For instance, children or elderly patients, especially those with some degrees of cognitive impairment, are the ones we need to be even more careful about and more aware that we can, without even meaning to disrespect this group of people, we can easily disrespect them by not engaging with them, but rather engaging with their carers. Imagine you seeing a gentleman who's got cognitive decline, but not engaging with the gentleman whatsoever, but engaging with his daughter who's brought him to the surgery. So, what the college has suggested is to check that we are being respectful by sharing our consultations with colleagues who are able to critique them and bring those blind spots to our attention, and also ask whether you're being sufficiently respectful to the patients which colleagues, experienced colleagues, have watched. Because sometimes it's when we raise these questions that experienced colleagues goes, you know what, true. Now that you've mentioned it, I didn't really think about it that way. But perhaps you could do this better. Next one is that ownership or responsibility for decision making was inadequate. And this is what happens when, for instance, a decision I should be making in terms of starting a medication, I refuse to start it, but rather I ask another colleague, let's say a condition whose treatment I should be starting in primary care. Let's say I suspect a patient with angina, for instance, and I should be starting them on GTN spray. But rather than doing that, I refer them to the rapid access chest pain clinic until that is started. And all things I am expected to be able to know at my stage, I then say, yes, I'm going to run this past my colleagues, or I drop an email for advice and guidance from a specialist on a subject that I am expected to take a decision on, then that will be the option picked in here. And what the college has suggested is to make decisions before debriefing a patient with your supervisor, such that way you're used to making your own decisions. If it turns out to be a wrong decision, you can always ring the patient back and say, look, I've discussed with my supervisor, this is what they've said. But what that will give you is that habit of you making your decisions and then learning from the decisions. The next one is teamwork and or understanding the role of others was insufficiently recognized or responded to. This is a doctor not recognizing the roles that can be played by other healthcare workers. For instance, we've got healthcare visitors and their role in safeguarding. For instance, you've got a gentleman with rheumatoid arthritis all over his hands, and we are not thinking of social prescribers. We are not bringing them in order to manage the condition. And what's been written here is that the examiners felt you did not demonstrate an adequate understanding of teamwork. For instance, whether the palliative team should be involved when a patient with cancer comes to end of life. Of course, they should be involved where appropriate. And so when we fail to do this, that will be the option that the examiners will be considering. And the suggestion to that is to attend and contribute to multidisciplinary team meetings in the practice, to perhaps sit with other members of the healthcare team to understand what their roles are. Even if you do not have the chance to sit with them, having informal chats about who to refer to them, who to seek their help concerning will go a very long way. The last one is that safeguarding concerns were inadequately recognized and responded to. This is rather important because if the examiner feels that we do not understand or demonstrate the principles of adult and child safeguarding, then they will pick this option. For instance, if we've got a parent who is struggling with substance abuse and dependency, it's only right that we are sure how their children are doing and that we are open to the possibility of safeguarding problems. For instance, if a woman is disclosing a domestic abuse, for instance, it's only right that we are asking if the children are affected or not. And how that person comes to the surgery and they look frail, they look unkempt, they look like they are not feeding well. It's only right that we're highlighting whether a case of neglect might be going on in here or not. And the suggestion as per the college is to meet your practices safeguarding lead and to attend a few safeguarding meetings to ensure that your level 3 safeguarding in terms of the adult and the child are not only up to date, but they are also documented, and to also possibly have a tutorial on the local safeguarding procedures and pathway for your area. Guys, those will be the feedback statement for the SCA exams, and those will be what exactly the examiners are looking for. Please watch as many times as possible, and if you've had your exam that has unfortunately not been successful, look for those statements that have been picked and particularly go through them, go through the explanation, and then begin to practice. Thank you so very much for taking time to watch this video. Please give me a thumbs up to encourage me to make further content. And if you haven't subscribed already, please do so. Share with colleagues, share with friends, so that we all benefit from this video. See you in my next video.